something or you got too much of something, the body readjusts to try to keep a balance between those two. Okay? But while it's doing that, guess what your water's doing? It's moving back and forth as all those little pieces move back and forth. Okay? So
the water compensates for homeostasis.
but sometimes the homeostasis can't remain balanced. It's very, very complex between the two things. And I have a calculation that'll come up in a minute to kind of show that a little bit. Because as you can see from these statements right here, total body water, there's no way to actually go into somebody's body and see how much water there is. So I can't go into a person's cell and see how much water's in there, the only way to really keep up with it, we can estimate, how many particles are in there through the blood work, osmotics, blood pressures. But anytime you go into ICU, they keep a very strict calculation. It's called ins and outs. Okay, so everything that goes in you, from IV fluids to drinks to anything, they measure all that fluid, and then they got a bag down there, or they'll give you a urinal that you urinate in. They keep up with everything that comes out. So that way they can start to see if you start getting fully loaded with fluid or not. Because like if you had a patient, we was talking about a ventilator, and they're doing really good on the ventilator, but then you take a look at their ins and outs, and they're 7 liters positive. But they don't look like they're 7 liters positive, but they are. You might not want to pull that ET tube, just because that's so much water on board. Just something to think about in the future. And that's reading it says, instead of clinicians relying, we rely a lot on history taking, physical examination. But the main things we're looking for, so hypovolemia. Okay? So when you say volemia, you're literally talking about the volume of blood in the body. Okay? Obviously, some of the signs you're going to be very thirsty. You're going to have very little urine output. So why would you have a thready pulse with hypovolemia? Why would it be thready?
Because you're low volume, so water's like in the blood.
No pressure.
Yeah, very little pressure. There's almost no volume. And I'm gonna tell you, when you're in the hospital and you're filling a patient's, and one of these days you're gonna go, that feels kind of thready. You'll understand what thready means. It is a certain feel from a pulse you get. It's kind of hard to describe it. You'll be in the hospital one day and you'll go, oh, that's thready. It almost has like a vibration feel to it. It's like, zzz, zzz, zzz. It almost feels, it's not strong, it's just weak and zzz. I don't know. It's almost like a vibration to me.
So is like hypovolemia the same as like dehydration, or is it a little different? Is it like nutrient based too, like everything?
Well, no, to say you're hypovolemic means you don't have enough water or enough volume. So it would be low. It would be low, yeah.
So would you be bradycardic too, or?
More up, probably.
Oh.
Since you got less blood volume, you
Yeah.
don't have to pump yet. You got to pump once you got faster.
Oh, okay.
That's usually when you feel it, it's fast and it's kind of weak, because when it pulsates, there's not a lot of volume, so it's just like, rather than, so it's doing little squirts rather than big old pushes. Thready pulse, low blood pressure, and obviously if you have low blood pressure, if you're laying down, you sit up, you might get dizzy, might even pass out. Decreased skin tuger, however you say that. I guess I should have Googled that. Anybody tell me what that is?
Where like you pull it and it stays up.
Very good. Yeah. If you take your skin and you pinch it and it stays pinched, that would be very high. Okay. I have seen this. This is real. It's crazy, but it's real. You get the sunken eyes. Of course, you get dry membranes, muscle rigidity, all that can happen. Because if you don't have much volume, you're not getting the electrolytes, you don't have the balance you should. If every one of those things we talked about, if any of those are out of whack, it throws off the system. Muscles don't move right, reflexes don't move right. You can't think straight. You need all those things in balance. If you don't, because you'll find a lot of these electrolytes that we go over is going to have kind of the same reasonings back and forth as to, if they're low, this happens, if they're high, this happens. What causes them to be low? A lot of times that's very common too. So elevated hematocrit, who can tell me what hematocrit is?
It's like the percentage of.
Very good. Why am I even teaching? Very good. So you take your hemoglobin times 3, and that's an estimated hematocrit, okay? And if you have a low hematocrit or a elevated hematocrit, then you're hypovolemic, unless it is blood loss. So why would it be elevated? Why not low?
Why would the hematocrit be elevated?
Yeah, why would my hematocrit, why would it read high instead of low in that case, if you're hypovolemic?
Because you're losing your other fluids, but you're still maintaining the same blood.
Very good. So if you have this much blood in there, or this much water in there, then things kind of space out like they're supposed to. But if you have a lot less blood, things are much more condensed, aren't they? So whenever you get it, if that's elevated, then it's pretty condensed, isn't it? It's not very spread out. Urine, a lot of times you end up with potassium loss through the urine, and we're gonna get into that in a little bit. You guys remember all the kidneys? The kidneys play a massive role in all these electrolytes, as you will know.
Would you say this box 5-1 is good to know all that stuff in there?
Yeah, it's good to know. Just know it. This is definitely good knowledge when you're in the hospital assessing your patient. Because remember, as respiratory therapists, every year we become more than respiratory, right? So it's good to know these electrolytes that don't specifically deal with our stuff sometimes. Because if you're going to extubate a patient, you need to know the ins and outs of what's normal, right? That's kind of a nursing thing, isn't it? But no, we need to know. Because the docs look at us sometimes to help them make decisions, which is a huge compliment. Yeah.
Why would wheezing be a sign of hypervolemia?
Because if you have too much blood in there, things can kind of swell together, I guess you would put it. And think about what exactly is a wheeze.
It's like the narrow.
So it's an area in the airway. Can secretions cause a wheeze?
Yeah.
So the secretions can actually come close. So what happens is those airways get closer, secretions get closer, and when they go to exhale, it causes that vibration between the two, between the liquids. So secretions can cause that, water can cause that, fluid. So the lungs kind of swell, and the lungs are huge sponge absorbers. So, yeah. You guys remember some of our patients who are wheezing? Remember I said, how about cough for me? And the wheezing disappeared. That wheezing calls from secretions. There's so many different kind of wheezes too, but you'll get used to that in clinic. So for the next several electrolytes, make sure you guys know the normals. That is something you won't see on the test. Sodium, I've never been anywhere where the normals were any different than this. 135 to 145 is like the same anywhere I've ever been. I'm sure there's one hospital somewhere that uses different measurements, but not around here. So in that statement right there, sodium is important for a variety of cell functions and for osmotic pressure. Now that first statement right here, variety of multiple membrane functions, that's true for all these guys. Know that. Magnesium, phosphate, all of them. That second part, now that's more true for sodium than most. You guys remember when we do the anion gap? It's everybody against this guy, isn't it? That's how big a boss this guy is. Everybody against sodium. And even whenever that happens, there's still a gap. Sodium's like more, so there's still unmeasured. Yeah, so sodium's the boss. It is the most common cation in the blood. I like it. Surprise, surprise. So here we got pseudo-hyponatremia. What does pseudo mean? It means fake. When you look at this, almost think of it like a lab error, although it's not. Okay? So pseudo-hyponatremia, so you guys were just telling me a minute ago, if you have a certain amount of blood volume, that, you know, that the sodium's in a certain amount of blood volume, you get a good number. But if that volume increases, it lowers my sodium. If it decreases, it gets higher. But it's also true if I take that blood volume and I put a bunch of fatty acids in there, a bunch of glucose in there, I put a bunch of other things in there too. So the body volume can actually be normal, but because there's so many particles in there, and they're taking up so much space that it seems like the sodium is low, but actually it's not. Okay, and that's what they mean by pseudo or isotonic. It's not real. Okay. So a lot of times when you get in there and you get to looking and you see something like this, you see hyponatremia, one thing is you look at, what is their cholesterol? What is their lipids? It's usually lipids. And people with diabetes is usually what call them. Because there's so much glucose in the blood, or there's so many lipids. Like maybe, you remember me telling you about that patient I stuck and the blood didn't look real? It was like sometimes it looks like water almost, and sometimes, like that one time, it looked like the hot red that you spray on a sports car. I mean, there's all kind of things that can get in there. But essentially, substances expand the serum volume, not the blood volume, the serum, but not the blood volume. And these are toxins that you can end up getting from factories somewhere where you work, as well as glucose, proteins, lipids. And you guys remember that one? Mannitol? That was the one with I was talking about, well, we haven't really been into PFTs yet, but when we get into PFTs, you may give mannitol, depending on which hospital you work at, you end up doing PFTs. That's one of the drugs we can give to irritate the airways. So just as you can see here, this is the calculation I was talking about before, okay? So you guys remember, we literally took sodium and compared it to everybody else, right? So what we're gonna do is we're gonna say sodium, and we're gonna say everybody we compared you to must be equal to me. We don't put potassium in here. Potassium's what, 3? It's not gonna make any difference anyway. So you take sodium and you double it. That takes all the positives and the negatives, combine them. That should be all of your electrolytes. Everybody against sodium. You take your BUN, what's BUN?
Blood, urine.
So this right here is floating around in your blood too. So you divide that by 2.8, and what's your glucose? So you take those and that'll give you the osmolarity of the blood. So I want to show you this. So what's normal, right in the middle, what's normal sodium?
135 to 145.
135, 145, 140, we'll use 140. Okay? So what's 140 times 2? 280. Okay. All I did was calculate sodium, right? So for a normal osmolarity, it ranges from 285 to 295. Sodium all by itself equals 280 of that. Because so essentially this counts for everything except for those two. Okay. So the bond is usually, it's lower than 20, so we'll say 15, what is it? We'll say 18. So bond, what about 3 instead of 2.8? We'll say it's 18, 6, 12, 18, so that'd be plus 6. Glucose, a good glucose number, we'll say is 100. And we'll say that 18 is actually 20 just to make it easy. So plus 5, that's 11. 280, that would be 291.
So you would normally divide it by 2.8 and 82?
Yep. I'm just making it easier for, yeah, I'm not. That's way too much work for that. But the main reason I wanted to show you this is a calculation that you can do to see the osmolarity of the blood. But also just take note, sodium equals almost all of it. And that's the reason we say where sodium goes, water goes. All right. So this is hypertonic hyponatremia. All right, so what does the word hypotonic mean? I'll give you a hint. It has to be compared to something else in order to be hypertonic, hypotonic, or isotonic.
Compared to a negative positively charged ion?
With ions.
Yeah.
But with and so for this, we're also going to compare, this is in reference to water.
Is it low salt? Low salt hypotonic?
Okay. Now, a lot of times you'll hear hypertonic, hypotonic, and they're talking about salt water. Okay? But just keep in mind that's hypotonic saline, hypertonic saline, isotonic saline. This is just hypotonic. So if you took this right here, let's say this was a cup of water. This is a permeable membrane, okay? And we put some big things in here, let's say 3. It can't pass through the membrane, okay? And then we'll put 3 little small things in here, 3 little small things in here. They were small enough to fit through the thing, they were permeable, they came over here. And then we put some, we'll call this glucose. 3 glucoses, managed to make it to both sides, okay? So based on the definition of what I told you before, which one of these is hypertonic? Can you tell me why? So, yes, if you have more particles in one side than you do the other, it's hypertonic, okay? So remember, if the particles go from this side to this side, there's a balance. It doesn't even matter, because they keep a balance, right? But if you got particles that can't cross that membrane and come over here, they have to remain over here. So this has got more particles than this one. That's what hypertonic, it's called tonicity. And this has more particles, this is hypertonic. This would be called hypotonic in comparison, just because of the total number of particles, okay? Now the particles that can move across, that's usually called your, I just forgot the name of it, osmolarity. So the osmolarity type things generally can be moved. So depending on the cell, sometimes sodium is tonic, sometimes it has osmolarity. It all depends. Nothing about cells is simple. People get degrees in cells, just a cell. So you go to this cell, potassium can freely come out. You come to this cell, potassium ain't never gonna leave. You go to this one, all different kind of functions. But this generally means this. So let's say I had water in here. Which side is my water level gonna rise?
On the hypertonic level.
Bingo.
Because it's attracted to it.
Remember, the water is attracted to the more particles. So it literally raises the water level here, and it diminishes, the water level will drop over here. Because the water can go back and forth across the membrane. It can do that with any cell. So let's step this up a notch. Let's say I took this, I'm just trying to be quick, and we put 3 particles, there's a cell up here, 3 particles, there's a cell up here, 3 particles, 3 particles. And now we're gonna put some different particles in here, like that. And down here, we're just gonna put